First and foremost, let me thank all of you for having come to this conference, because no conferences are successful until we have a large audience. I purposely chose this subject of autoimmunity and antigenic targets in the ovary because we've heard enough of endometrial implantation, we've heard about a lot of factors in the endometrium, recurrent implantation failures. But what we've not really heard about is how does immunology affect the ovary? And if we have to look at the immune system, it's a very complex entity designed to eliminate foreign intruding antigens and is influenced by and in turn influences the function of the reproductive system. We do know that immunology plays an important role in pregnancy, in recurrent pregnancy loss. We also know that sex hormones and the immune system are involved in this. And in infertilities in the 1980s, for example, 1970s, we thought sperm antibodies was important, so used to do a bit of a washing so that the surface of the sperm head would be devoid of those antibodies and therefore the pregnancy would occur. We also know that there is some loose association between endometriosis and infertility and immunology. And of course, the most established one is the premature ovarian failure. Now, the immune cells we know are the B cells, which is the adaptive immune response of the lymphocytes. We have the adaptive part, and then we have the innate immune response, that is the phagocytes. So the B cells, which is part of the humoral immunity system, which is the antibody production. The T cells, as we also know as the thymus cells, are the helper or the inducer cells, the suppressor cells, and also the cytotoxic cells. Now, if you were to look at the immune cells over here, they all start with the stem cell. And then you get a myeloid precursor. Yeah. You get a myeloid precursor, and there you get all the platelets, eosinophils, neutrophils, basophils, and of course the mast cells and the monocytes. However, you have also the lymphoid system, where you have the helper T cells, the suppressor T cells, the cytotoxic T cells, the B cells as well, which again gets converted in the tissues as a plasma cell. The immune system and sexual dimorphism. Here as well, whilst the males are more susceptible to infection, females are not behind in terms of an autoimmune response. So they have a 2.7-fold risk to develop autoimmune disorders. Let's look at the T cell in implantation. Implantation is known to be followed by a local immune response characterized by the presence of a large population of T cells, many of which express surface markers characteristic of activated cells, and these T cells specifically recognized paternal alloantigens. The natural killer cells has made its face in the late 2000, and we find that these natural or the NK cells, as we see, tend to be maximum during the implantation phase, and whether they are important or not has not yet been clearly defined. However, the quantification of these natural killer cells, that some amount of natural killer cells are required for implantation, but if it is in excess, then you have a problem. So the distinctive feature of the uterine mucosa during the reproductive cycle is the presence of a large population of natural killer cells at the time of implantation, which are in close contact with the invading placental trophoblast tissues. 67% of doctors have accepted increased evidence of poor responders over the last 10 years. Because at most times when we didn't know what came out or what was wrong, we would say it was a viral etiology if you were in the 1950s and 60s, and then you would say that by the time you reach 2000, you say it could be an autoantibody or an antibody response or an immunological response, because this was like the waste box where you didn't know what happened, you just dumped it in that. But now trying to take out this junk box and then try and identify what exactly is this immunology that we are looking at. So does unexplained infertility mean unexplored? And do we see the light at the end of the tunnel? So let's see what we look. So is autoimmunity the answer? So autoimmunity in the ovary, and this is a difficult topic, and believe me, just for this lecture, I went to prepare this because I really did not know much about it. Historically, way back in 1933, the first study with the association of adrenal autoimmunity, 2 cases of premature ovarian failure have been recorded, and then, of course, implicated in premature ovarian failure, unexplained infertility, polycystic ovaries, and endometriosis. So, for the immunological features of autoimmune premature ovarian failure, let's look at the humoral immunity, the cellular immunity, and of course the histological findings. So, the autoimmune factors in premature ovarian failure, we're looking at the humoral immunity over there. You have a steroid cell antibody and you have an anti-ovarian antibody. The steroid cell antibody is in association with adrenal autoimmunity in almost 78 to about 100% cases, and other cases of autoimmunity would be less than 10%. Now, if you look at the anti-ovarian antibody, the prevalence in the premature ovarian failure would be around 30 to 67%, the variation because we do not really have a proper cutoff, and less than 5% in the normal population. Other antibody panels are also present over there, but these are the ones that are mainly important for us. So, although a number of tests have been developed to detect these antibodies, neither their specificity nor their diagnostic relevance has yet been established. However, looking at the autoimmune premature ovarian failure, if you look at the immunological factors of the cellular immunity, the presence of CD4 cells and the T cell count, the activated T cells and the major histocompatibility class 2, and the altered blood monocyte response to chemotactic agents. So, let's go to the histological findings, because many a time the histological findings will be the clincher over here. And if you see, 40% of the follicular type will be the ones that are autoimmune ovaritis and of course associated with adrenal disease. In the histological picture, you will find some follicles present. So it is not as if to say that it's absolutely devoid of follicles. But the non-follicular variety, which is complete destruction of the follicles and the end stage of the follicular form, is the end stage of the follicular form, which is basically no follicles in the ovary. So, ovarian autoimmune disease, the clinical concepts and animal models was actually in Nature in 2014. So, what are we looking at these anti-ovarian antibodies, which comprise almost of 33 to as much as 61% of unexplained infertility. So, we could actually not dump the 10% of unexplained infertility as is easily said, but we certainly dissect out that 10% and say of that at least a third to 2/3 of the unexplained infertility can be explained on the anti-ovarian antibodies. And the independent markers as no relation of FSH or inhibin B levels. So, are we looking at an early stage of autoimmune failure? So, looking at the PCOS picture, and we have been really baffled as to why some PCOS respond to very, very slight doses of gonadotrophins or clomiphene citrate or letrozole, and why are some ovaries so resistant that the maximum dose does not actually give the follicles out to maturity. And many a time we wonder whether we have to drill the ovaries because the stroma is very thick, or we're actually at this thing, have we reached the optimal level? So 50% of the PCOS have the ovarian antibodies. Autoimmune ovaritis, even ovaritis or pelvic inflammatory disease, which appear innocuous at the time when it occurs, and later on you find that these antibodies appear. And with cystic aspects, so many times you will find a lot of cysts in the ovary, and you may not get eggs out of that. Now, is an empty follicle syndrome, for example, an expression of an ovarian antibody positive? Now, that is where the research is going towards. So, PCOS women have higher incidence of autoimmune thyroiditis, and that is something that we have to keep in mind. So, with PCOS patients, suggesting if they have a subclinical hypothyroidism, it's best to test the antibodies in these cases, and then let's see what we can do for them. Now, in endometriosis, we all know with endometriosis that the quality of the oocytes are compromised, and of course we know that many a time you get the follicular fluid in the the follicles also get altered because of endometriosis. So multiple endometrial antigens like candidate genes are targeting the autoimmune endometriosis, and autoimmune immunity plays a role in the onset of development. Now we know that interleukin 6, interleukin 10 have been implicated, and the HOXA10 has been very well validated as the homeobox gene is expressed in the developing uterus and participates in the endometrial development and may also contribute to endometriosis in the ovary. So look at the immunological part of the endometriosis. The interleukin, and what is its effect on infertility? It is the intrafollicular estrogen level variation that has a direct effect on the quality of the oocyte. The RANTES is also a group of these things which are regulated on activation normal T cells expressed and secreted. So they are responsible for the inflammation and cytotoxic effects. And the IL-10 is also at the G0, which is the resting phase of the follicles and arrest of the granulosa cells. Now, in endometriosis, the peritoneal environment becomes extremely important for, of course, looking at the reactive oxygen species production. What would be the general kind of role? Would be, of course, the leukocytes secreting the growth factors and cytokines, and then it induces inflammatory response, and of course, reactive oxygen species that are formed, that again has a negative impact on the tissue. The other way, in a specific example, is the PF leukocytes, which secrete the IL-1 beta, and then RANTES attends to this particular thing and attracts the monocytes and the memory T cells, has this antigen-antibody reaction, cells destroyed, resulting in the ROS production. So what would be the antigenic targets? Now, if you thought sperm antibodies was the only thing that we knew about immunology, then my dear friends, I think we need to look beyond that as well. Now, we have here the somatic component. What would be the antigenic targets for the somatic component? Would be the granulosa, the theca cells, and the corpus luteum. And next is the germinal component, is the oocyte itself, and the zona pellucida separating the above two. The molecular targets will be actually the gonadotrophin receptors and the gonadotrophin itself. So we need to look at the targets, and we also need to look at the subtypes of the steroids. So if you look at the targets, the target could be the adrenal cortex, the theca interna, interstitial cells of the gonad, corpus luteum, granulosa cells, and the placental trophoblast. But what would really be the subtypes are all the steroid productions. You've got the anti-21 hydroxylase, adrenal specific, and anti-17 hydroxylase. So basically the adrenal kind of hormones are all put in here. So what would be the germinal component, which is very, very important? The anti-oocyte antibody. The 125 kilodalton protein is important in the murine specimen, the knockout mice, when normal follicular development and growth and fertilization, but it arrests at a 2-cell stage. How often have we been confounded that you have very good fertilization, but then you have a 2 or 4-cell arrest, and then that follicle or that embryo does not go further. So are we looking at an anti-oocyte antibody here, which does not allow it to continue further? And are we going to subject this woman again and again to repeated IVFs when we know that there is a fertilization success, but the embryo does not develop from the second day onwards? So at least a 4-cell stage. If it doesn't go beyond that, I think one must look at the ovarian antibodies. The mater would be the maternal antigen that the embryos require. Recent studies say leucine-rich protein is very important in these cases. So these germinal component anti-oocyte antibodies are implicated in recurrent implantation failure and in the embryo arrest. Now this is another protein, and that is the heat sensitive protein, that is heat sensitive protein 19 beta autoantibody, and it can actually be used for early diagnosis or prognosis of autoimmune premature ovarian failure. And in such cases where there is a very early onset of premature ovarian failure, as evidenced by the dwindling AMH values and the increasing FSH values, can steroid therapy help in these cases is something. Let's just see what happens. So heat shock proteins are highly immunogenic. Prolonged or repeated asymptomatic chronic infections can result in these heat sensitive or heat shock proteins, and these antibodies could then target the ovarian antigens, leading to an early ovarian failure. So the presence of an anti-HSP90 antibodies could be used as one of the diagnostic markers for ovarian failure and therefore infertility. So these antigenic targets, we did hear about anti-zona pellucida antibodies sometime in the early 2000s as well. Only 2.4% of infertile patients way back in 1992 was recorded to have the anti-zona pellucida antibodies, but in IVF it is correlated with a low fertilization rate. So what about the molecular component of gonadotrophin receptors? How often have you seen when you give patients a very large dose of gonadotrophins and you still get no follicles coming out, making sure that the FSH is normal and the LH is also normal, and in such situations by giving larger doses of gonadotrophins you still do not get follicles. Now this would be the antibody to the gonadotrophin receptors. So the binding capacity here to bovine testes membrane extracts. So what is the biological activity here? The FSH induced progesterone synthesis or LH induced cyclic AMP production is at fault. So correlation could not be established in further studies. So this was the only study that was there, and so we need to look at more studies before we can get any meaningful results. Now, gonadotrophin injections can cause anti-FSH and LH antibodies. Even the injection that you use, especially the urinary products, you can have antibody productions, and poor responders, particularly 92%, had anti-FSH antibodies and 65% had anti-LH antibodies. So the molecular target here was the beta fraction of the FSH with immunodominant epitope between the 78 and 93 amino acid. So these are novel targets that we see now, and one has to go more towards the poor responders, the non-responders, and have a look at why exactly you get an empty follicle syndrome. Are we actually looking at the gonadotrophin targets, or are we looking at the anti-ovarian antibodies, is something which is for future research. The circulating anti-follicle stimulating hormone immunoglobulin A, that's the antibodies against the follicular stimulating hormone, that is anti-FSH, are present in infertile female sera, and anti-FSH IgG may diffuse along with the antigen into the follicular fluid during ovarian stimulation. So what are the recommended tests that we would look for in these cases? And that is the thyroid, then adrenal, and even diabetes mellitus. So looking at the thyroid antibodies, anti-TPO antibodies, we see that in almost 10 to 15% of infertile patients. They interact with receptors on the oocyte and impair the chances of fertilization and subsequent embryo development. Detrimental effect on embryo implantation is also noticed, and there is no consensus on the impact of anti-thyroid antibodies on the outcome of IVF yet. So, effect of anti-TPO antibodies on the outcome of IVF ET cycles was a small study conducted in our own clinic, a very preliminary study. The study was planned to evaluate whether the presence of these anti-thyroid antibodies is associated with an adverse outcome in IVF ET programs in terms of quality of oocytes retrieved, fertilization, cleavage rate, and implantation rate when compared with patients with thyroid antibody negative. What would the secondary outcome be? Clinical pregnancy, biochemical pregnancy, and abortion rates. So we are looking at basically the numbers were 50, and we were looking at just very, very preliminary, just out, that even if you looked at those who had the thyroid antibodies, 36% of them were positive, and of course the 42%. This is actually looking at the abortion rate, yes. The 24.1% for the abortion in those cases that had the antibodies, and 5.6% which didn't have the antibodies. So if you looked at the biochemical pregnancy rate, 24, again 0.1% with biochemical pregnancies in those that had the thyroid antibodies positive, and 5.6% in those that did not. But when you come to clinical pregnancy rates, those that had the thyroid antibodies, there was a 48% success, but a 77.8% in those that did not have the thyroid antibodies. So, what is the role of immunotherapy? There have been case reports, even in premature ovarian failure, where live births have been reported after corticosteroid therapy, but only one RCT where 35 patients were included, and corticosteroid versus placebo had no benefit at all. But a large amount of work needs to be done in this area, because whilst we are looking at good fertilization, what about those that get a 4-cell arrest, for example, or non-fertilization? I think a lot more immunotherapy or immunohistochemistry is something that we need to look at, rather than subjecting them again and again to stimulation, thinking that that was a bad cycle, so let's take another cycle. So where you have these things positive, it's important for us to take note of it and appropriately manage these cases. So what has been the conclusion so far? Autoimmunity has an important role, especially in premature ovarian failure associated with adrenal autoimmunity. Autoimmunity is likely, at least in some cases of unexplained infertility, PCOS, and certainly endometriosis. What has been the targets, novel targets that we have? That is the ovarian target. It's important to see the anti-ovarian antibodies and also maternal antigens that the embryo requires. The FSH beta antibody, because whether it is FSH and LH, the alpha chains are absolutely identical. It is the differentiating factor is the beta chains. So antibody against the FSH beta chain is something that we should be looking at, and looking at these people before we start stimulation. That would be almost screening. However, it would be better if they've had poor outcomes, poor responses, and then you do the FSH beta antibodies, and if you find that that is elevated, then certainly you know the answer as to why this is happening. Whether steroid is going to help in these cases is some time will tell, but at the same time, knowing that there is something wrong itself is, solving the problem, because many of the patients that come to you, not being able to tell them why this is happening becomes a big question mark as far as the patient is concerned, and puts a dilemma as to how you go treat the patient further. And of course, my dear friends, the aid our better understanding. After getting all these antibodies, it certainly aids our understanding of the pathophysiology for the ovarian antibodies. So, if you think you know the XYZ of infertility, think again. We still are at the AB, A, G. Antibody and antigen. So my dear friends, we still are at the beginning and not at the end. We start all over again. And that's the beauty of infertility. We are still embryonic. Okay? And thank you all very much.
Thank you, ma'am, for the thought-provoking address.